Good morning. It is such a pleasure to be gathered with everyone this morning, and I now have the pleasure of introducing our next speakers as well. We are grateful to share that this general session is sponsored by Michigan Medicine, and it's entitled Breaking Barriers in Epilepsy Research and Therapies. Dr. Nusha Mihaylova is an epileptologist for adults at Michigan Medicine, and Dr. Garnett Smith is a pediatric epileptologist at Michigan Medicine's C.S. Mott Children's Hospital. So we will hear their presentations and then conclude with 10 minutes of your questions. So it's a pleasure to have Dr. Mihaylova and Dr. Smith with us, so let's give them a warm welcome. Good morning.
Good morning, everyone. I'm really excited to be here. I have already seen some familiar faces in the audience, and that makes it even more exciting. I'm really honored and humbled to be here in front of you and to have the opportunity to talk about new pharmacotherapies for epilepsy. Let's see if I can navigate this. Yes. So, epilepsy is this enduring predisposition of the brain to generate seizures, a condition that carries a lot of neurobiological, cognitive, psychological, and social consequences. Epilepsy is very common, as you know. It is the fourth most common neurological disorder. It affects more than 3 million Americans and more than 52 million people in the world. 1.2% of the US population lives with active epilepsy. At least 15% of the general population will have a seizure in their lifetime, and 1 in 26 will become an epileptic. And approximately 150,000 new diagnoses are made each year in the United States. The incidence and prevalence of epilepsy is about equal in men and women, maybe slightly more prevalent in men, and it tends to peak during early childhood and later in life in elderly patients, which is probably reflecting also the higher incidence of brain tumors, dementia, and stroke in elderly patients. Seizures are sudden, uncontrolled, abnormal brain electrical activity, and they can present with a wide range of symptoms depending on which part of the brain is affected. Epilepsy is the disease that causes recurrent, unprovoked seizures. For us medical professionals, it's really important to define the type of seizures, define the type of epilepsy, so we can select the most appropriate treatment. So in general, there are two types of epilepsies, focal and generalized. Focal seizures start in a small part of the brain, as opposed to generalized seizures that start altogether in the entire brain. Focal seizures are a little bit more frequent than generalized seizures. Seizures have different range of severity, different causes, and often they're accompanied by many other medical conditions. The anti-seizure medications are the mainstay of treatment of epilepsy. And the good news is that we have more than 40 anti-seizure medications nowadays that can be used as monotherapy or in drug combinations for treatment of epilepsy. They're not curative, but they treat effectively seizures and they can prevent seizures. Only a century ago, we had a handful of medicines available for clinical use. And in the last 2-3 decades, there have been more than 20 new novel pharmacotherapeutic options approved for treatment of epilepsy, which measures a remarkable success. Unfortunately, despite having more than 40 anti-seizure medicines, there is a proportion of patients, about 30% of patients with epilepsy, who cannot fully control seizures through pharmacotherapy. And these are patients who have pharmacoresistant epilepsy or medically refractory epilepsy. The diagnosis of pharmacoresistant epilepsy is established after a patient fails to control seizures, to achieve good seizure control after 2 adequately dosed and well-tolerated medication trials. There is no single mechanism that can explain drug resistance. It is multifactorial and it can vary from patient to patient. How do anti-seizure medications work? I think we really have to understand what the pathophysiological mechanisms of epilepsy are to understand how anti-seizure medicines work. Pathophysiology of epilepsy is really complicated and incompletely understood. Overall, seizures are a result of imbalance between excitation and inhibition. There is either too much excitation or insufficient inhibition. And excitability of the neuronal cells, of the brain cells, can be controlled by ion channels, which are actually proteins that serve as passageways for different ions, mostly sodium, calcium, potassium, chloride, as you can see here in the picture, into and out of the brain cell. Anti-seizure medicines work on different ion channels and on different receptors that can be either found on the surface of the neuronal membrane, inside of the neurons, or on the synaptic membrane, as you can see in the picture. And synapses are those small gaps in between the neurons that help them communicate via transmission of special chemicals called neurotransmitters. Some of these chemicals are very important for seizure generation, and I want to mention two of them because we will refer to this information later on when we review some of the new anti-seizure medicines. Glutamate is the most potent excitatory neurotransmitter in the brain, and GABA, which stands for gamma-aminobutyric acid, is the most potent inhibitory transmitter in the brain. So some of the anti-seizure medicines work by suppression of the excitatory mechanisms. Some of them work through augmentation of the inhibitory mechanisms, and some of them have those combined actions. How do we make progress? Innovation within the pharmaceutical sector can be classified in many different ways, depends on context and degree of drug novelty. When it comes to new anti-seizure medicines, there are two big categories of medicines. Evolutionary drugs, these are the drugs that improve the existing medicines. They are a result of semi-radical or incremental innovation, and the goal with those drugs is to eliminate side effects without affecting efficacy. And the other big group of anti-seizure medicines is revolutionary drugs. These are the drugs with novel mechanisms of action, a result of radical innovation. The goal with those is better seizure control than the existing drugs. And I would like to review with you the newer anti-seizure medicines that have been approved over the past 10 years. They're not in any particular order, so I will start with S-carbazepine acetate that is known by the brand name Aptium. And this is a drug that is a result of incremental semi-radical innovation. This medicine was first approved as an add-on therapy for focal onset seizures, and then followed by an indication for monotherapy after a successful completion of monotherapy conversion trials. A feature of novelty for this drug is that it is a sodium channel blocker, just like its predecessors, carbamazepine and oxcarbazepine, but it actually potentiates the slow inactivation of sodium channels, something that has not been seen with carbamazepine and oxcarbazepine. Another feature of innovation is that this drug can be taken once a day. Class 1 evidence, in which this is the strongest evidence for efficacy. So class 1 evidence for efficacy as adjunctive therapy in treatment focal epilepsies shows very good outcomes with 35 to 39% median percent reduction in seizure frequency. Retigabine or ezogabine, this is one medicine with different names in Europe and United States, is a medicine with a radical degree of innovation. It is a first-in-class medicine that works as a potassium channel opener. Unfortunately, this medicine was withdrawn from the market back in 2017 because it turned out that it caused bluish pigmentation in the skin, in the nails, and retina. Now we have a new molecule, and I'm very excited about that. It's called ZIN 1101. This is a drug a smaller molecule with much higher affinity and selectivity to potassium channels. Again, it has this novel mechanism of action that no other medicines have. And it does not cause that side effect of bluish pigmentation because it does not have the structural components of the other drug that caused it. So there have been phase 2 clinical trials with ZIN-1101 that showed very promising results. So about 55% median seizure reduction was seen in patients who took the maximal dose of 25 milligrams a day, and about 40% median seizure reduction was seen in patients who took lower doses. So this is pretty significant, impressive numbers, because these were all patients who had pharmacoresistant epilepsy. In other words, they failed multiple other medicines. And I just want to mention that actually at the University of Michigan we have 2 ongoing clinical trials with the ZIN-1101. One is for pharmacoresistant focal epilepsies and the other one is for pharmacoresistant primary generalized epilepsies. So if you're interested in any of these, please find me after the session. Perampanel, known by the brand name Fycompa, is a medicine with a radical degree of novelty. It works in a specific subtype of glutamate receptors, and I mentioned to you that glutamate is the most potent excitatory neurotransmitter in the brain. So perampanel actually blocks so-called AMPA subtype of the glutamate receptor, and it suppresses excitation, abnormal excitation. It is indicated for monotherapy of focal onset seizures as well as add-on therapy of primary generalized seizures. And class 1 evidence shows very good efficacy and good tolerability, meaning no bad side effects at maximal doses, which can reach 8 to 12 milligrams a day. A retrospective pooled analysis of patient data from 44 studies from around the world, from 17 countries, showed seizure freedom rates in patients with focal onset seizures and generalized onset seizures 64% and 69% respectively. And this is a very, very impressive number. And also a very high responder rate. And responder rate actually refers to 50% or greater seizure reduction during treatment. So very high responder rates, 84% in patients with focal epilepsy and 93% in patients with primary generalized epilepsy. Neuropsychiatric side effects could be something we sometimes see with this medicine, but my personal experience shows that if I start at a low dose and escalate slowly over prolonged periods of time, I usually avoid those side effects. Brivaracetam or Briviact, this is a medicine with semi-radical degree of novelty. It's an evolutionary medicine, evolutionary to first class levetiracetam. It works in a specific type of targets, protein that is called synaptic vesicle glycoprotein 2A, and it is found in the neurons. And this protein is involved in the release of neurotransmitters that are associated with seizure generation. So brivaracetam has much better permeability through the blood-brain barrier and faster action compared to levetiracetam. It is approved for monotherapy or add-on therapy for focal onset seizures, and there is strong class 1 evidence for good efficacy. Behavioral side effects that sometimes we encounter with levetiracetam are much less frequently seen. And on this slide, I also show you the results from multiple clinical trials for this drug's efficacy. At 12 months of treatment, about 36% of patients had more than 50% seizure reduction, and 11.7 patients remained seizure-free. And this is a big number, given that all these patients, again, they had medically refractory epilepsy, failing a lot of medicines. The retention rate for patients on brivaracetam is very high. It's 71% at 12 months, meaning that patients tolerated the medicine quite well. Everolimus, known as Afinitor, is a medicine with incremental semi-radical drug of novelty. It's actually an old medication that was first approved about 20 years ago as an immunosuppressant, and then just more recently in 2018, the indications were repositioned to use for focal onset seizures associated with tuberous sclerosis complex. And probably many of you know that tuberous sclerosis complex is a neurogenetic condition that is a result of genetic mutations, and it is due to dysregulation of so-called mTOR pathway. It can affect the brain and also other organs and systems. So everolimus actually improves other tuberous sclerosis manifestations, such as subependymal giant cell astrocytomas and renal angiomyolipomas. These are, complicated words for different type of tumors. And I think that it's really impressive. I almost think that this is a medicine with radical degree of novelty, because it's probably the only one of the anti-seizure medicines that addresses the underlying pathophysiology of the disease causing seizures, and it doesn't only treat seizures. So I'm showing you the data for drug efficacy from the pivotal clinical trial with everolimus, where the medicine was used as an add-on therapy for focal seizures. The responder rate, again, so people had more than 50% seizure reduction. The responder rate was 47% at 1 year, and it increased to 58% at 2 years of treatment. Again, people who had different type of seizures that failed multiple medications. Cannabidiol, or Epidiolex, is a medicine with a radical degree of novelty. I'm not going to spend too much time. I understand that there is another session focused on this medicine later. So I just want to say that this is a highly purified CBD, just one of the multiple components of medical marijuana, that is indicated for add-on therapy of seizures associated with two devastating epilepsy syndromes, Dravet syndrome and Lennox-Gastaut syndrome. And more recently, Epidiolex was approved for treatment of seizures in patients with tuberous sclerosis. The exact mechanism of action is unknown. We think it's a multi-target drug that affects different receptors and different targets in the brain. About 42% of patients with Dravet syndrome achieved 50% seizure reduction for convulsive seizures in particular, and about 39% of patients with Lennox-Gastaut syndrome achieved 50% seizure reduction in drop seizures, and these are bad seizure types that can cause falls and injuries. The side effects are typically mild. Somnolence is what I typically see in my patients, but sometimes diarrhea, high fevers, and reduced appetite can be seen. And Epidiolex is really working well for patients who are on high-fat diet and ketogenic diet. Fenfluramine, or Fintepla, is one of the newest anti-seizure medicines that has a semi-radical degree of novelty. It was introduced in Europe actually many, many years ago when it was first used to treat obesity. So it was used as an appetite suppressant. Unfortunately, the medicine was withdrawn from the market because it caused bad side effects, heart valve disease, and pulmonary hypertension. And just more recently, the medicine was approved for treatment of Dravet syndrome and Lennox-Gastaut syndrome associated seizures. It has this unique mechanism of action by working on serotonin receptors and increasing serotonin concentration in the brain. What I know from studies and from talking to pharmaceutical representatives is that these bad side effects that are still listed on the drug information are really not seen in any of the patients who were treated for seizures. But yet we're still careful, and we require echocardiogram before we start treatment, and then we do that periodically throughout the treatment. And I'm showing you on this slide the results of several clinical trials with Fintepla. On the left-hand side, you can see the results in patients with Lennox-Gastaut syndrome. These are pretty impressive numbers in my mind. There was a mean seizure reduction for 45% of patients who had grand mal seizures, and 77% of patients who had tonic seizures. And these are seizures that involve body stiffening, falls, and cause injuries. And then on the right-hand side, you could see the results in patients with Dravet syndrome who were treated with Fintepla. So there is a significant reduction, almost 80% of grand mal seizures in this patient population. Cenobamate or Xcopri is another new exciting anti-seizure medicine with semi-radical to radical degree of novelty. It's a multi-target drug. It works on different receptors. It has a combined mechanisms of action, which is what explains its novelty. So it potentiates GABAergic transmission, and you remember that GABA was that most potent inhibitor in neurotransmitter. And it also blocks the voltage-gated sodium channel, so it reduces excitation, abnormal excitation in the brain. It is approved as monotherapy as well as add-on therapy for focal onset seizures in adults, and it has this convenient once-a-day dosing regimen. The median percent change in seizure frequency during the first week of treatment with Xcopri was 40%. This is really significant compared to placebo. And this significantly increased over time to 60% reduction in seizure frequency at 12 weeks of treatment. And 1 in 3 patients had 0 seizures in over 1 year on treatment. Ganaxolone, I personally do not have experience with this drug, but I really wanted to mention it to you because it's also one of the newest anti-seizure medicines. It's a medication with semi-radical novelty. It treats seizures in people with a specific neurogenetic condition that is called CDKL5 deficiency disorder, or CDD. And this is a genetic condition, X-linked condition that can affect male and female, a little bit more severe in males. And it presents not only with seizures, but also causes a lot of behavioral, cognitive problems and developmental problems. So those patients have different type of seizures, and usually very refractory seizures. So ganaxolone seems to be working very well for this specific patient population. It's a GABAergic medicine. It potentiates the GABAergic neurotransmission. 4 times reduction in median seizure frequency was seen in 1% of patients, and 1 in 4 had at least a 50% seizure reduction for different seizure types. The side effects are not severe, but sometimes we may see sleepiness, drooling, fevers, and allergic reactions. Stiripentol is another new anti-seizure medicine. It is actually the only treatment that is specifically indicated for seizures associated with Dravet syndrome in children as young as 6 months, who are also taking clobazam or Amphi. Stiripentol is a GABAergic medicine. It potentiates the GABAergic neurotransmission, and it acts in a specific subtype of GABAergic receptors. In 2 randomized placebo-controlled trials, patients with Dravet syndrome experienced significantly fewer clonic and tonic-clonic grand mal seizures. Reduced convulsive seizures by 84% median seizure reduction, with 39% of patients becoming seizure-free only after 2 months of treatment. The side effects are sleepiness, decreased appetite, sometimes weight loss, tremors, and agitation can be seen. And now, quickly, I would like to review with you some of the newer seizure rescue medicines. And seizure rescue medicines are those medications that we use only in emergent situations, usually at times of seizure clusters or prolonged seizures. And seizure clusters are those stereotype, repetitive, unremitting seizures. So there have been 2 novel medicines approved over the past few years. They both come in a novel form. They're nasal sprays. The first one was Nazilam nasal spray, and the other one is Valtoco. So Nazilam is administered as a single spray, which is a 5 milligram dose into 1 nostril. And if the seizure cluster doesn't resolve in 10 minutes, then a second dose can be given in the opposite nostril. So the approval of Nazilam was based on a placebo-controlled trial with a primary efficacy and point of treatment success defined by 2 components. First one, seizure termination within 10 minutes, and the second, no seizure recurrence within 6 hours. So the medicine passed those components. Side effects are usually very mild: somnolence, headache, nasal discomfort, sometimes throat irritation, and runny nose can be seen. And the other one that I mentioned, the other nasal spray, is Valtoco. It has the same indications, so it's usually used for patients who have seizure clusters. It can be used for prolonged seizures, and prolonged seizures consider the seizure that lasts more than 3 minutes. It is administered as a single spray in one nostril, and then a second dose can be given in the opposite nostril if the seizure recurs in 4 hours. It's been studied quite a lot and mostly compared to the diazepam rectal gel. And it shows, the nasal spray shows less variability in the bioavailability compared to the rectal gel, which makes it easier to predict its dosing. Side effects are sometimes somnolence, of course, like with all benzodiazepines. Bloody nose can be seen, nosebleed can be seen sometimes, a nasal discomfort. And just recently I was asked by a patient how to use this spray, so it's really easy. That's why I'm showing a picture. It comes as a pre-filled device, and that has to be placed in the nostril, and then the plunger has to be pushed firmly to deliver the dose. Valtoco is dosed by age and weight. And just a few words, I think my time is almost up, but just a few words about novel therapeutic approaches. So brain inflammation has a role in the development of seizures and can be targeted as a new therapeutic option. Normally, inflammation protects from infections or injuries, but dysregulated inflammatory responses can lower seizure threshold. It can change the permeability of the blood-brain barrier for anti-seizure medicines. So there are some experimental studies now that demonstrate anticonvulsant activity of specific non-steroidal anti-inflammatory drugs that seem to improve the blood-brain barrier permeability for anti-seizure medicines. Synthetic neurosteroids seem to be another option for treatment of seizures. Many of you know that hormones such as progesterone and estrogen have a lot to do with seizure control and can be associated with a specific type of seizures in women. And ganaxolone is a synthetic analog of allopregnanolone. This is one of the metabolites of the natural progesterone. So ganaxolone has a very strong GABAergic potential, and phase 2 clinical trial showed quite good efficacy in patients with focal onset epilepsy. And currently there is a phase 3 clinical trial that is evaluating ganaxolone at a higher dose in adults with focal epilepsy, and we're hoping to see that higher doses will turn out to be more effective. And on this slide here, I'm showing so many other new anti-seizure medicines that are in the pipeline for treatment of epilepsy. And I'm only showing you this information because I want to end up my talk on a positive note with words of encouragement. There have been so many new novel pharmacotherapies discovered in the past 2-3 decades, and there are many more to come. And we're hoping to have new pharmacotherapies that will be not only symptomatic, will not only treat seizures, but they will also treat the underlying pathophysiological mechanisms of epilepsy, which will be a huge step towards curing of epilepsy. These are paintings from people with epilepsy. And as you can see in some of those paintings, seizures are scary. But I see that the predominant color in those paintings is bright. I see a lot of yellow and pink. And this is what I have learned from my patients. You never give up. And I don't give up with you because I know that there is a hope for the cure of epilepsy. Thank you for having me today.
Slide. It is a tremendous honor to be with you all today. I'm humbled by the invitation to speak, and I think it's especially appropriate that I follow Dr. Mihaylova, who was the fellowship director for my epilepsy fellowship. She taught me how to care for patients with seizures, and I'm so grateful to be here with her. I'm also grateful to be here with all of you because I consider families and people with epilepsy, my patients, to be my teachers as well. I've been taught so much by the people that I interact with through the care that I attempt to deliver in treating patients with epilepsy. So my goal today, well, first I should start with, I don't have any financial relationships to disclose. I will be discussing, because we're talking about the threshold and innovations, treatments that are off-label for many of these technologies. My goals today are to help answer the following questions, and I appreciate the question that was asked earlier about, has anyone here had the experience with their doctor recommending surgery? My hope is to answer the question, when does an epilepsy specialist consider that surgery is indicated for the treatment of epilepsy? What types of surgical treatments are available? And what are the frontiers in these surgical treatments of epilepsy? What are the latest things coming down the pipeline, and what are we thinking about for the future of treatment treatment of epilepsy with surgery? So this slide is similar to one that Dr. Mihaylova shared earlier, and I've added some highlights here about other therapies besides medication that are available, and sort of when they came. And you'll notice there's a theme here, and hopefully that laser, but our neurostimulatory therapies are sort of the newer things that are coming along in the treatment of epilepsy. We'll talk a little bit more about that. With all of the medications and all the innovation in medications for the treatment of epilepsy, why do we need surgery? Well, the answer to that, and it's already been talked about, is that as you add medications, a smaller and smaller proportion of patients become seizure-free, and we're left with a very large portion of the population of people with epilepsy who continue to have seizures despite our best efforts with medication. So we explore other options, and among those is surgery. The goals of epilepsy surgery are first, of course, to achieve this holy grail, right? Seizure freedom. Because when we remove that unpredictable factor in a person's life of, I don't know when I'm ever going to have a seizure, we can reduce a lot of the disability that comes along with epilepsy. And we can improve, hopefully, quality of life. And in children, in the population that I teach, when we achieve better seizure control, we really influence and improve the development of our patients with epilepsy. They achieve milestones like neurocognitive development, motor development much better when seizures are under better control. So how do we determine whether surgery is an option? It's like real estate, location. That is the single most important factor in understanding whether surgery is an option, and if it is, what options are available to a patient, right? And this is just an illustration of the motor area in the brain and our understanding of how different locations in the brain's cortex are associated with different functions. That becomes very important when we're mapping a patient's brain, when we're trying to understand where do we intervene, can we go in and do a resection, or are we going to negatively affect these essential functions of the patient's brain? We work very hard to understand where seizures are coming from and what other functions are associated with that location in our patients. Of course, we start with a detailed history and examination. Sometimes, and some of the really influential teachers of clinical epilepsy throughout history have talked about how the magic in understanding where seizures come from really is in the history that you get. That story of, this is what I experience at the onset of my seizure, or this is what my caregivers see when I have a seizure, can sometimes give you very important clues about where seizures are coming from in the brain. We can talk about things like, do you have a genetic epilepsy syndrome? Do we understand how that might affect the development or even the structure of the brain, and might that influence where seizures are coming from? We do monitoring in our epilepsy monitoring unit, something called phase 1 monitoring, where the goal is to capture a seizure with the EEG running, right? And so we're sometimes in this paradoxical situation where we walk in the patient's room and say, we really want you to have a seizure right now, so that we can understand where this is coming from. And we'll sometimes wean medication. We'll do things like keeping people awake for a long time, or provoking maneuvers to try to make seizures happen, because we really want to understand as best we can what the electrical brainwaves show to help us understand where a seizure might be coming from. We work closely with colleagues in radiology and functional imaging. There are lots of different kinds of imaging studies. It's beyond the scope of the discussion today, but we can image brains in many ways to help us understand where seizures might be coming from. We can do other tests. There's something called a WADA test, where we actually put half of a person's brain to sleep and see what we interrupt. Do we interrupt their memory? Do we interrupt their language when we do this? It can help us lateralize or determine the laterality of these very essential functions of the brain. And we work together with neuropsychologists, with social workers, with speech and language pathologists, because their evaluations and their expertise can also add very important information about how is this patient's brain being affected by their seizures, and might that give us clues about the localization. We also, and I think the importance of this point cannot be overstated. I personally very strongly believe that the best approach to the surgical treatment of epilepsy must be collaborative. You have to work together as a group. And that collaboration includes the patient and their family, their caregivers, but it also includes all of these other people with expertise in neuropsychology and radiology and social work and all of these things. You have to have input from all of those groups, because you have to create an environment where we're addressing not just the electricity in someone's brain, but everything that goes along with that in their life to ensure the best outcomes. So Dr. Mihaylova also touched on this. It's very important when we do this evaluation to distinguish between generalized onset seizures and focal onset seizures. Not because one is more amenable to surgery than the other, but because our approaches vary considerably. So this is just an example, and I hope you can appreciate this. This is the EEG of a patient having an absence seizure. It's a generalized seizure that happens and involves the whole brain all at once. So the patient might be fine for the first 3 seconds in this EEG, and then the whole brain starts firing. And there's really no way to distinguish any one particular region of the brain. But the other feature here, of course, is it's obvious when a patient's having a seizure and not on the EEG. This is an example of a patient having a focal seizure. And you don't need to know this, but the top half of this page is the left hemisphere of the patient's brain. And there is a seizure happening in there, but it's quite subtle. What this EEG tells us is that the seizure clearly has an onset in the left hemisphere, but we still need to work harder to understand exactly what part of that left hemisphere is producing the seizure. Hopefully that gives you a little bit of a flavor. Sometimes we have to work really hard to understand where these seizures are coming from precisely. The thing we aim for first, because it has the greatest potential to lead to seizure freedom and to have all of these other benefits, is resective surgery, or creating a lesion that isolates or removes the source of a patient's seizures. So we talked about all of these approaches. We do something called intracranial EEG. And more, we do what's called stereotactic or stereo EEG, where we use the patient's imaging and a robotic system to implant electrodes directly into the patient's brain to understand very precisely where these seizures are coming from. If we're successful with that, if we're able, so the optimal outcome, if you come to this point in a surgery evaluation, is we capture seizures, we localize them very precisely, and we're able to offer the kind of treatment that either removes brain tissue or creates a small scar in the area where seizures are coming from, and hopefully removes seizures completely. There are limitations to that, of course. If you have seizures coming from the parts of your brain that are intimately involved with production of language or memory or sensory or motor function, we just avoid removing those areas, of course. We don't want to create more problems for our patients. I will add the caveat, because I treat patients who are pediatric patients with profound amounts of seizures. They might have 300 seizures in a day. And we have conversations with families about risks and benefits. It might be very beneficial in that case. A family might say, we would tolerate our son or daughter having a weak right arm if we removed all of those seizures. So it's never a cut and dry or totally black and white approach, but it's a discussion of risks and benefits. We do have data available sort of across many centers in many countries about how often we achieve seizure freedom when we do a resection in epilepsy surgery, right? It depends a little bit on the location. And the best numbers for a long time have been with temporal lobe epilepsy. So when we're able to localize seizures to the temporal lobe and do a resection that removes the seizure focus, at least 2/3 of the time, and in some populations much more than that, 90% of patients will become completely seizure-free after our surgery. Outcomes are very similar in the pediatric population. But that still leaves a proportion of, well, first of all, there's a proportion of patients that just cannot have a resection. And that leaves a proportion of patients, even if resection is a possibility, who continue to have seizures. So this brings us to sort of the theme of the talk for today, I think, because this is where innovation and technology are advancing very rapidly, and this is sort of the cutting edge of surgical treatment of epilepsy. It's our neuromodulatory therapies. So imagine, for instance, a case where a patient has seizure onset in the part of the brain that controls hand motor function. Well, and they're otherwise, they're a college student perhaps, so they're very functional. They would be totally devastating to lose the function of this hand. Well, we can offer other things. We have implantable devices or other things where we can introduce a system that stimulates the brain or a portion of the brain or a nerve that's connected to the brain that decreases seizures. So the first one I'm going to talk about, and these are in no particular order, is the responsive neurostimulation system. The brand name for this, the company is NeuroPace, and I see Mike sitting over here. But this device is a device where a stimulator is implanted in the skull. It's connected to leads that are implanted at the seizure focus, at the area where the seizure is coming from. It continuously monitors brain activity in that region, and when it detects a seizure, it provides a stimulation that will hopefully abort that seizure from growing or from continuing on any longer. And I have to add that there are caveats about this statement that we implant these in the location where a seizure is happening. This is one of the frontiers of this. I'll talk about that in a little bit. One of the most important features of the RNS system is that because it's continually recording, it has the ability to give us feedback as families and caregivers and patients with epilepsy and providers, healthcare providers. It can actually teach us about where a patient's seizures are coming from. So we can capture these recordings when seizures happen, and it can inform our treatment going forward. So this is an example of the feedback that we get. So this is what's called an ECOG recording, electrocorticography recording. This patient had a seizure that started from the right hemisphere. You don't have these two electrodes are in the right temporal lobe, and it spread very quickly to the left hemisphere. This patient actually, before we implanted the device, we had the idea that they were having independent onset of their seizures from the left and right temporal lobes. Now that the device has been in for a couple of years, we understand that 90% of this patient's seizures actually start on the right side. They may spread very quickly to the left, but they start on the right, and that has important implications for treatment down the road. That's actually a huge advantage of this system. We get this feedback that is EEG data that can teach us very important things about the patient's seizures. So detailed feedback is a huge advantage of this RNS system. Our ability to detect seizures using this system and then stimulate add energy into that seizure circuit to hopefully make seizures go away. There is a broad range of parameters that we can adjust to learn together how to detect these seizures more effectively and then how to treat them. It does require a high degree of confidence about the location of seizure onset, because our goal is to implant these electrodes into that area so that we can get the best feedback and the best treatment potential there. Next steps here, though, as we advance the frontier, we're learning that there are important structures in the brain that are involved in seizure circuits almost all of the time. There's a structure called the thalamus. A lot of you have heard of this. It's a bundle of a lot of neurons that lives deep down inside the brain that's connected to the cortex, the outside surface of the brain, all over the place. And so there's a lot of research and a lot of development going into stimulating in the thalamus to affect broader circuits rather than trying to put our devices just in the location where seizures come from. That's sort of a segue to talking about deep brain stimulation, which is targeted. It's a totally different system. That's primary target is stimulation in the thalamus, in this deep area of the brain. You can see it's a device that lives under the skin. The stimulator is here. There's a wire that's tunneled under the skin, and then electrodes that are implanted deep down into this structure in the middle of the brain. And this is sort of a cartoon depiction, and sorry, my slides didn't translate the pictures very well, but there are three nuclei, three locations where the neurons live that are connected to different seizure circuits. There's something called the anterior nucleus. There's something called the centromedian nucleus, and there's one nucleus called the pulvinar nucleus. And these are nuclei, bundles of neurons that are interconnected to different regions of the brain that may be important, and we're still doing research and trying to understand exactly when we need to implant electrodes in these different locations. The DBS system does give us feedback. It doesn't capture EEG the same way that the RNS system does, but it can do things. It measures something called local field potentials, which are discharges in the brain that are felt in the thalamus. And we can use that data to tailor our stimulation to hopefully achieve better seizure outcomes for our patients. So it does provide feedback, but it does it in a little bit different way. Advantages, and this can sometimes be very important. We don't have to spend quite as much time. When we're thinking of stimulating the thalamus, we know where that is already. And we know that if we implant electrodes in the thalamus, we're not going to cause things like muscle weakness or sensory changes or memory changes for a patient. So we don't have to spend quite as much time or effort really pinpointing the focus of seizure onset. Or we might already know that seizure onset can happen in many different areas, and we say, well, let's go to the thalamus, which is connected to all of these areas. There's a shorter period of learning. So once the device is implanted, we don't have to spend as much time tailoring our detection of seizures or understanding how to do this stimulation as we go forward. And it allows, actually, with a handheld device, it allows the patient some limited control over the settings of this device. So they can do things like turn it on when they feel like they're at higher risk, turn it on to higher settings, or things like this. It does give us more limited feedback. It's a little bit less customizable, I would say. But the next steps here, and there's sort of a crossover between these two technologies, because we're getting better and better at understanding the information that the DBS system gives us back. It's looking a little bit more like RNS. And RNS can be used to stimulate the thalamus, right? So there's some crossover, some overlap that we're still trying to understand. There's a lot of research and experience to be gained before we fully understand how to distinguish these two. And neuromodulatory therapies, vagal nerve stimulation is a very important therapy that is sometimes more approachable for patients and families because it's a lot easier to implant. It actually doesn't involve brain surgery at all. So this is a device, again, the stimulator and the battery are implanted under the skin. A small wire is tunneled and wrapped around the vagus nerve. It provides stimulation on a duty cycle. It's basically on for a minute, off for about 5 minutes. That puts energy into the system and has a beneficial effect on decreasing seizures. The primary advantage of this system in my mind is that, first of all, it can be used with other neuromodulatory systems. You can have VNS and DBS or VNS and RNS. It's very easy and minimally invasive to place. It doesn't involve a lot of time in the hospital or pain or anything like that. The disadvantage is that it's hard to predict a patient's response to this system. Some patients do beautifully. Some patients will have benefit, but it takes a number of months or even years for that benefit to be fully felt. And some patients really won't experience a difference in their seizures. And frustratingly, it's hard to predict which patients will have the excellent benefit from this system. Fortunately, that bar is low, right? It's easy to get, it's minimally invasive, and it's something definitely to consider in a patient who has medically refractory epilepsy. There is sort of the newest iterations of this device will do things like detect a sudden increase in heart rate that might be related to seizures, and will kick the device into a higher stimulation mode. So there is a little bit of, we're sort of, the technologies are providing more and more feedback and closed loop control that can sometimes have benefits for patients. So I'm conscious of time. I do want to thank all of you for allowing me to be here. I work with a number of people in sort of the research that I do. I've received funding from the National Institutes of Health to fund my research, and yeah, I guess I'll sit down. We're happy to take, I think we have some time for questions, right?
Thank you, Dr. What a helpful presentation, and thinking about breaking barriers and new treatments and new surgical opportunities. Thank you so much. So it is time for your Q&A, and we have some people with microphones who are going to come around the room. We have about 10 minutes. Please keep your question brief so we can get as many as possible, and just keep in mind our doctors are not able to make specific recommendations for your health, but they can address this topic generally, and I know they have a lot of great knowledge to share. So please raise your hand and we'll have your questions.
How do you know if you're a candidate for those devices?
Great question. Hopefully this on. The starting point is, do you have medically refractory epilepsy? If you do, you may be a candidate for surgery, and it's time to ask your neurologist about whether I'm a candidate. So that's sort of there's a lot of work that goes into distinguishing, is it RNS better, is DBS better? That might depend on the place where you're getting your care, because different places have different experiences with these technologies. But the starting point is, have I been on at least 2 medications? Am I still having seizures? Well, I need to talk about, am I a candidate for the surgical treatment?
Okay, over here.
Thank you both. I have 2 questions. Something in the Epidiolex part caught my eye, that in higher concentrations it acts as an inverse agonist. Does that basically mean it just can make seizures worse?
This is on already. This is one of the multiple mechanisms of action for Epidiolex. It does not make seizures worse. Actually, it potentiates the serotonin system in the brain, and it's been shown that higher levels of serotonin actually have protective effects, anticonvulsant effects. So I believe, if I'm not wrong, that this was the reason why Epidiolex was also approved for patients with tuberous sclerosis complex.
Okay.
This indication came after the medicine was approved for Lennox-Gastaut and Dravet. If you remember from my slides, also there is this other medicine, Fintepla, that actually has a very similar mechanism of action. It potentiates the levels of serotonin in the brain. So this is how it shows its anticonvulsive features.
Thank you.
You're
And
welcome.
then secondly, where you talked about brain inflammation, obviously I would think a high level of inflammation is easy to tell, but how do you test for lower levels where it could be having an impact?
These are just experimental studies yet, so I am afraid I can't fully answer this question. I just wanted to make everyone aware that this is something that's been looked into as a potential target for disease-modifying therapy. So I'll stop there because I don't want to give a wrong answer to this interesting question.
I had a question about with the brain surgeries on, like, is it really worth it? Because myself, I've had 2 brain surgeries, a wake left temporal lumpectomy and a craniotomy. My seizures has reduced dramatically, but the mental side effects to the brain surgeries, now I think different. Like, I went along with it because I thought, I wanted to be fixed, but now I be thinking, because I have, like, now they say I show signs of autism. I have very major sensory issues, and I be thinking, would a seizure have been better? Because now I have, like, get offended easy, did all that to be, and I be thinking, was a seizure for me is only a few minutes. It would depend on what type of seizure, but I come back and I'm normal. But now I'm honest, I can admit I have sensory issues with getting my left temporal. I had my craniotomy removed, and back then I was only 20 when I made the decision. I didn't know your hippocampus and all that has to do with memory. and I just was, just signed to have my brain surgery. But now I'll be thinking, the side effects, I have memory problems and all that. Like, do you guys feel that is better than the actual seizure? Because I second guess it now.
Thank you so much for sharing that. I think what you've highlighted is an extremely important issue about this discussion that has to happen about the risks and benefits. And unfortunately, we're often in the position where we can't predict exactly what's going to happen. But the hope would be, and really this is where the educating the clinicians part comes in, having that feedback from patients like yourself reinforces the importance of having these difficult conversations about, here's what we could do, here's what may happen, does that feel worth it to you? I think the most important judge of that is the patient themselves. Does this feel worth it? So I'm sorry that you've had that experience. It's a difficult thing. Right. So we can make seizures better. Is it worth it in the context of everything else that's connected? And that's a very important conversation to continue having. Thank you for raising that.
Okay, we see a question in the back. Oh, there we go. Thank you.
Hi, I have a question, and that would be about what side effects do we know about RNS and DBS on the long term? Not just like what happens during surgery, like bleeding or things like that, but what effects have those surgeries and that continuous stimulation in the brain from those devices?
Such a good question. These technologies, in my opinion, have not been around long enough for us to have a very detailed discussion about long-term side effects. I can tell you what I've seen, and this depends on where we're implanting the device and the settings that we're using. And again, a conversation about what you experience with stimulation, is it still worth it if it's preventing seizures? But I've seen things like mood changes at certain settings. I've seen things like, it's very common actually, depending on where we are, if we turn it up too high, someone can feel some tingling in their fingers or toes or on a part of their body. But that conversation and continually learning and adjusting our settings in response to that, in my experience, we've been able to address side effects when they do appear. But side effects are possible, and it's definitely something to have a conversation with a provider about if you notice that your mood is different or behavior is different, or you're having other symptoms as a result of that stimulation. It's a great question.
You mentioned a few medications that increase the serotonin levels. I was wondering, is there a way to test your serotonin level? Is that something to look into? Is there other ways to increase the serotonin level if you're on a medication that is not known to increase the serotonin level?
That's an interesting question. I'm not aware of any way to test your serotonin level. As you probably know, serotonin is that chemical that can affect your mood. So typically people who have more serotonin are happier, and the opposite, people who have less serotonin are depressed. Unfortunately, I don't know how we can test for levels, but there is a hypothesis that certain antidepressants that actually increase serotonin levels in the brain can have some anticonvulsant features. And it's not unusual for people with epilepsy to suffer from depression or anxiety and to take this specific type of antidepressants that increase serotonin.
Is there ever a difference in effectiveness of being on a name brand medication as opposed to a generic?
There has been some literature that actually compared generic and brand name medicines, and I know how patients feel about it. I know how I feel about it, but I just want to say that the literature actually doesn't show a significant difference between brand name and generic preparations. Yet sometimes I prefer to try brand name just because there is a little bit more of a predictability, if I can say that. If I always know that I get it from the same manufacturer, that the patient gets exactly the same ingredients in the medicine. Another reason for me to try brand name is side effects. Sometimes if I find a medicine that really works for my patient, controls seizures but causes side effects, I've seen that by switching to a brand name formulation, the side effects are less noticeable, more tolerable. But in general, actually, literature shows that there is really no significant difference between both formulations.
We have time for one more question. I see a hand up here too.
Thank you for your presentation. You mentioned that there are several sprays that we can use during the seizure, but can we use them prior to seizure? Like when we feel it coming, can we grab them and just squeeze and see if it can help?
Yeah.
Thank you.
Yeah, thank you for this question. Yes, this is one of the indications that I recommend for the use of these nasal sprays to my patients. If you have predictable seizures, if you recognize your aura, symptoms that you can rely on, and you know that this is going to turn into a seizure, absolutely, I recommend the use of those medicines because it can actually prevent the seizure from further build-up and becoming a bad seizure. So, yeah.
Okay, thank you so much, everyone. You had great questions, and please join me in thanking Dr. Mihaylova and Dr. Smith. Thank you so much.
We're grateful to share that this session, The Impact of Cannabis on Seizures in the Brain, is sponsored by the Henry Ford Health Comprehensive Epilepsy Program. My name is Carla Boyd, and I serve as a member of the Board of Directors at the Epilepsy Foundation of Michigan. I'll ask one more time if folks can make their way back to their seats. Thank you. Okay, I'll repeat that. I'm Carla, and I serve as a member of the Board of Directors at the Epilepsy Foundation of Michigan. And more importantly, I'm the very proud mom of Lane, and she's a young adult living with juvenile myoclonic and absence epilepsies. I have the honor of facilitating this next session and welcoming our speakers. They'll present for 30 minutes, and then we'll have an extended Q&A because we know there's a lot of interest in this topic. So here to present on this subject are Dr. Gregory Barkley, adult epileptologist, and Dr. Jules Constantinou, pediatric epileptologist from the Henry Ford Comprehensive Epilepsy Program. We are very lucky to have both of them here with us today. And not only are they both world-class epileptologists, they're both world-class human beings. Please join me in welcoming them and for this session.
Good morning. My name is Gregory Barkley. I'm going to talk first, and then Dr. Constantinou is going to talk after me. One of the challenges in talking to a group like this about cannabis is the folks in the audience range from people who use cannabis every day to those who've never used cannabis but have been told by their friends and family that CBD oil cures everything. So what we're going to try and do is start from the beginning, kind of go through some of the basics about the cannabis plant and how it mimics some of the compounds in our body, how it might work to stop seizures, and then we're going to try and save as much time as possible to let you ask your questions. So cannabis has been used for millennia to treat seizures. Its history goes back 12,000 years or so in China, where it was known for its medical benefits. It's been written about in ancient texts in India, where one of the strains of cannabis plant is native, and it's been written about throughout the Middle East and even into European countries into back as far as 400 or 500 years. The benefits of cannabis have been recognized for treatment of seizures among the many ailments that it's been used for. And probably the first relatively modern records come from about almost 1500, where it was recognized that cannabis was very helpful in controlling a young man's seizures, but it was also recognized that there can be a dependency issue in the case of the same young man. So like all medications, there are both benefits and potential side effects from the use of cannabis. So what we know in the United States is that there are records going back 70-some years of the use of cannabis, and I think this is an interesting article that is from 1949, where a group of patients who sound like have Lennox-Gastaut, who were institutionalized in Utah, were given cannabis products that had been, or derivatives that had been used instead of the drugs that they were being given at the time, which were basically the choices between phenobarbital and phenytoin, which is the brand name Dilantin, and various derivatives. And they showed some improvement in the control of the use of the medication. So we have records going back many, many years in the United States of its effectiveness. There are actually 3 cannabis plants, and so I want to talk a little bit about that because we have the medical marijuana option here in Michigan, and there's a lot of marketing and hype about the cannabis, and so I'm going to try and help you understand about a little bit about the plants. So the closest relative to the cannabis plant is the hops plant, and as those of you who drink beer know, it gives a particular taste and smell to beer, and the cannabis plant itself is also a very fragrant plant as well. So the 3 plants are the cannabis sativa, which is the plant that's native to China, and it's very tall. This is the one that is used to make rope fibers, as well as for the medical compounds. One of the major compounds in this plant is called that's not a cannabinoid, is called alpha-humulene, and the various other products besides the cannabinoids in the cannabis plant also may have medical benefits. In general, the cannabis sativa from strain has a higher ratio of CBD to THC, and we'll get into what those terms mean in a minute. The second plant is the cannabis indica, which is the plant that's native to India, and it has a higher ratio of THC to CBD. And what's interesting about both cannabis indica and cannabis sativa is they're a little bit tricky to grow because, like the poinsettia plant, they have to have a period of darkness every day in order to flower. So if you were growing it in your house and you actually turned on the lights at night, it wouldn't flower. The third plant was only discovered 99 years ago, and it was in Siberia. It was called Cannabis ruderalis, and most people not have heard about this one. But this one is different because it's growing up in northern climates where there isn't a very long growing season, so it auto-flowers, so it doesn't need that photo period. So when people go into cannabis shops, they will sometimes see mixed mention about that these are from plants that were auto-flowering, and this is because there's a high ratio of this. Now, while people who are in artisanal cannabis shops or hear people talking about this is a sativa or this is an indica strain or various things, one has to think about this like talking about various types of apples. We all know what an apple looks like and tastes like, but we can all tell the difference between a Honeycrisp or a Macintosh just by biting into it and tasting it. All of the apples that we buy, all the tomatoes, all the fruits and vegetables we have are all hybrids that have been blended to try and bring out certain properties. And it's safe to say that all of the cannabis plants that one can pick up products in artisanal shops are also hybrids. So whether they say they're a hybrid or not, they're all blended with various strains to try and bring out certain kinds of properties. What in the business of cannabis, they talk about this calling the entourage, the mixture of the chemicals that bring out certain qualities of the plant and the way they make you feel. The best way to probably think about cannabis plants is the chemotype, and there are really 3 chemotypes. One chemotype is the high THC to CBD ratio. THC is the cannabinoid that makes you feel high. And these are kind of the party cannabis strains for people who are aiming to go to a concert or something, and use that for the purposes of being euphoric. Chemotype 2 is where there's a relatively balanced ratio of THC and CBD. And so there will be a part of the intoxicating effects of the THC along with the effects of CBD. And then chemotype 3 are the high CBD strains, which are what most people with epilepsy are interested in, because when you're trying to control seizures with cannabis therapy, you need to be able to function during the day and not be intoxicated. So you will want to look for strains that are mostly CBD or as close as possible. Dr. Constantinou is going to talk about this some more in his set of slides. This all became possible because of the 2013 Farm Bill, sponsored by our own state senator, Senator Stabenow, who's the lead negotiator of the Farm Bill every 5 years. And in that Farm Bill, there was a definition of industrial hemp. So hemp is a cannabis plant that has low percentages of THC. And so that bill allowed universities and state agriculture departments to start working to reintroduce hemp, because while cannabis had been part of the USP, the official compendium of drugs, since the 1850s, it had been removed from medical use in the 1930s as part of the war on drugs, misbegotten war on drugs. And this was the mechanism by which it allowed the modern day use of cannabis, CBD strains of cannabis to be used. It's been further, the subsequent Farm Bill made it actually even easier. Now, when I talked about the prohibition about cannabis, that has to do with the Drug Enforcement Agency. The DEA is a police agency. It has nothing to do with science. It has nothing to do with medical uses. And for their own reasons, the DEA has been part of the war on drugs, has had this prohibition about the use of THC and has scheduled it as Schedule 1, saying it has no medical use. Now, the FDA has taken a scientific approach to this, and there are actually several approved cannabis products, even though the whole plant has no medical use. Both THC and derivatives have been approved for about 20 years. And CBD has been approved for 5 or 6 years as for the treatment of epilepsy specifically. The same company that makes the approved CBD oil in the United States also sells a product in Canada and in Europe that's a 50-50 mixture of THC and CBD, and that is marketed for relief of pain and spasticity, and it is part of the official protocols on the therapy options for treatment of conditions like MS in Europe and in Canada. So how does the cannabinoid system affect seizures, or what happens when you use cannabis? So cannabis, like most plants, many of you are drinking coffee here, that has caffeine. Caffeine mimics a natural product in our body that alters the level of a compound that's part of the regulatory activity of the body called adenosine. People are familiar with tobacco. With nicotine and tobacco, there are nicotine receptors all throughout the body. And the cannabis plant is no different. It's used a different system, the cannabinoid system. And the cannabinoids made by the body are called endocannabinoids. And the cannabinoids that are found in plants are called phytocannabinoids. So when we look at cannabinoids and we say, how do they work? They work to affect the body in various ways through various receptors. Dr. Constantinou is going to go through that in a bit more detail than I am. But it's clear that there are effects, particularly on memory and learning, and this has been studied in terms of its effects on memory and learning, particularly with THC over the years. And we are pretty confident that THC in the developing brain can have some adverse effects on your ability to learn and to recall. So a note of caution for people who are contemplating THC use in adolescents and even young adults about their cognitive performance with THC. Most of the role of the endocannabinoid system is in helping us to relax, to sleep, to feel at ease, to have a sense of being a pleasant state. And we sometimes, some of the things that have been attributed to other compounds are probably, when studied scientifically, are actually part of the endocannabinoid system. Many of you in the room do regular exercise, and you're probably all familiar with the term the runner's high, which is attributed in the popular press to the role of the opioid system in our body. But really, when you study it in detail, it's part of the cannabinoid system that gives us that sense of joy when we are in that groove of exercise or running. So we have a crowd here, and one of the issues that's always important to talk about any drug for the use of treatment of seizures is what happens if you're taking this during pregnancy. I have in here the package insert information on Epidiolex, where they, if you read through the fine print, gave extremely high doses to animals to the point that they gave lethal doses and the animals died, which can happen with any drug, even salt or water can if you give too much of it. But it didn't seem to have any clear effects on the developing fetus. We don't know, we do know that there's an uncontrolled trial of cannabis in the United States going on, in that studies have shown somewhere between 5 and 30% of women report using cannabis during their pregnancy because they wish to. And so we have children that are born every day in the United States that have been exposed to cannabis, mostly THC strains of cannabis, during pregnancy. And that is not something that we recommend. I think that this whole set that I'm presenting is being recorded, and I have a hyperlink to the national, to the official registry of information on what we know about that. In Michigan, we were one of the earlier states to be to approve the use of cannabis for medical marijuana therapy. And when this law was passed in 2008, on the behalf of the Epilepsy Foundation, I went and spoke before the commission, and I think that on behalf of the foundation I was able to have some influence, because I said when people take cannabis for medical therapy, it's different than people who are buying cannabis to go to a party, because when we use medications to treat seizures, we take it every day. We are used to getting a supply that lasts a month or so. We want the same strength on every time we get it. And so the things that we thought are important from the point of view of the foundation is that every product that's sold for cannabis therapy as medical marijuana needs to have testing to show that, one, there are no dangerous compounds such as heavy metals or pesticides in the product, and that the product has that the major cannabinoids are listed, and so we know exactly what we're getting. The one thing I will say that seems to be the custom at all the dispensaries in Michigan when you're buying artisanal cannabis is that the bottle will, if you're buying a bottle of gummies, it will say so many milligrams, and what those milligrams on the label is not how many per gummy, it's how many is in the entire bottle. But they all do it the same way, so you have to try and look carefully at what you're getting to figure out how much am I really taking. And then, like any other therapy, when you're taking medication therapy, you want to try and have a consistent dosage every day. So, that's my little introduction. Now it's Dr. Constantinou's time to go through a little bit more details.
Well, thank you, Greg. Thank you, Brianna. Thank you, Carla. Thank you, Shannon. Thank you, Epilepsy Foundation, for all that you do. And it's always a great pleasure to participate and just see all the familiar faces. I feel a little bit of a fraud sitting next to Dr. Barkley, who is one of the pioneers and one of the true experts of cannabis use for epilepsy in Michigan and in the United States. So accept what I say with humility, and I'll do my best. So, you know, when the pharmacology of cannabis is very complex, and I spent a couple of hours mugging it last weekend so that I could be up to date, but it is very complex, it's very mind-boggling, and we don't understand a lot about the way that cannabis works, but we do have a cannabis symptom in our brain. It's called the endocannabinoid system, and the two main synthesized cannabinoids in our brain are anandamide and 2-arachidonyl glycerol. And these, the receptors that these work through is the CB1 and the CB2 receptors. So the CB1 are presynaptic. That means they're in the synapse and the network. They're before the actual junction of the neurons. And these are highly expressed in areas of the brain, the hippocampus, the amygdala, the cingulate, what we call the limbic circuit, which is an important circuit for memory, emotion, for generating seizures. And CB1 is inhibitory, as Dr. Barkley says. It dampens activity before the synapse in the presynaptic. And the way it does is it modulates or mediates other neurotransmitters. CB2, the receptor, is somewhat surprising. It's only got limited expression in the brain, and it's mostly in the spleen and the bone marrow, in the immune system, in macrophages, and in microglia. And the microglia are the clearing houses in the brain. They clean up things and help synapses form, and maybe they have some anti-epileptogenic properties. They not just, because as you know, most seizure medications are just anti-seizures. They mask the symptoms. They don't actually impact on the process. So yes, the surprising thing though is the anti-seizure properties of cannabis are not mediated by the CB1 system. When we think about the phytocannabinoids, so these are the chemicals that Dr. Barkley's been talking about, and these come from the flowering marijuana plant, and there's over 100 different cannabinoid compounds, only 16 in men for consultation. So the two main ones are the THC, which is the psychoactive portion. That's the stuff that makes you high, the delta-9 tetrahydrocannabinol, and then CBD, which is a cannabidiol, which we think has the anti-seizure properties. There's a lot more interest in THCA, which is the precursor chemical to THC. So when you got your joint, you got to light it up, and the smoke and the heat changes the THCA to THC, but there's some interest in maybe THCA as having anti-seizure properties. The CBDA, which again is the the precursor molecule for CD. CBG, I love the name, cannabigerol, and there's something called CBGA, which is the mother of all the cannabinoids. And there's some work in Australia where they've looked at that. So as we said, the psychoactive properties of cannabis are mediated by the CB1 receptor. And THC, there's mixed reports of seizure decrease, seizure increase. CBD does not activate CB1. It's not psychoactive. You don't see tolerance. That's one of the drawbacks of THC, is that you get used to it after a while. And there's many ways that are hypothesized on other calcium G receptor protein, serotonin, calcium modulation, anti-inflammatory effects. So what are the artisanal cannabinoids? And I think before the pharmaceutical preparation of Epidiolex, cannabidiol became available, there was a lot of interest in Michigan, and perhaps still. Dr. Barkley and I would be interested to hear about what the perceptions are. But the cannabis oils, the artisanal CBD, have variable levels of CBD and THC. Now, the maximum ratio of CBD to THC that you get without subsequent purification is 20:1. So if you look at the dose of CBD that has anti-seizure properties, which is 10 to 20 milligrams per kilogram, so 300 milligrams of CBD, which would be a good dose for a 3 or a 4-year-old, that would equate to about 15 milligrams of THC. And that's similar to the maximum daily doses of Marinol, which is the synthetic tetrahydrocannabinol. And as Dr. Barkley says, there's a lot of variation in the products. Many products have CBD quantities well below those used in clinical trials. So really getting your product tested, getting levels done. And in one study, the variability varied from 0.1 milligrams per ml to 655 milligrams per ml. So that's a huge variation. Another study looked at, well, how often is the product correctly labeled? And 30% of the time it's correctly labeled, but many times it's either over-labeled or under-labeled. So a lot of times you're not getting what you think you're getting. Of course, it's costly, we have to be wary of contamination, heavy metals and solvents and pesticides. So I think Dr. Barkley told us about the long interest in cannabis as an anti-seizure medication, but I think there was a renaissance in Charlotte. You'll remember Charlotte's Web, and she was a 5-year-old girl with Dravet syndrome, and she was also on Onfi or clobazam, and she had up to 50 generalized tonic-clonic seizures per day. They added the high CBD strain cannabis extract, the famous Charlotte's Web, and we had a 90% reduction in seizures. And that's and after that, there were studies in the West, in Israel, and these were just studies of artisanal cannabidiol, and in Colorado, and again, it's about a third of people would have a 50% reduction of seizures, another third a 50 to a 75% reduction. But these studies were not controlled; they were just anecdotal observations, and so you always have to be wary with that. There's an expectation bias. So you may remember that families were picking up and moving to Colorado so that they could get THC. And so when they asked people, well, how do you think the CBD is going? Well, if I picked up my bags and moved to Colorado, it's better have worked. So, there was a 47%, 50% of people thought it helped, whereas those who had just, gone to the neurologist down the street, and there was only a 22% responder rate. This was a meta-analysis in 2018 by Pamplona, and he compared, so when we think about artisanal, we have the broad spectrum CBDs, and we have the full spectrum CBD. So full spectrum's got a bit of THC in it. Broad spectrum has got no THC. Dr. Bark has already talked about the entourage effect. We've got all these phytocannabinoids, the terpenes, and the idea was that CBD-rich extracts in a lower dose were often favored over just pure CBD in a higher dose. And to this day, I will have families that don't want to try Epidiolex. They say that, the artisanal CBD works better for us. These are studies that, so I'm not sure what our time is because I can't see a clock.
We're fine.
So these were the studies which led to approval for Epidiolex, which is cannabidiol, which is a highly purified, highly reproducible CBD. You know exactly what you're getting. It comes as a syrup. It's strawberry flavored. It's in sesame oil. What they did was there were 2 studies for Lennox-Gastaut syndrome, and as you know, Lennox-Gastaut syndrome is one of the most difficult epilepsies there. Well, it's a very difficult. It's what we call a developmental epileptic encephalopathy, where you have multiple seizures, drop seizures, markedly abnormal EEG, and often a significant cognitive and behavioral burden. And the hallmark seizure of Lennox-Gastaut is the drop seizure. So kids that have Lennox-Gastaut, adults with Lennox-Gastaut, because we don't outgrow it, we're in helmets, because the sudden drops can cause injury, and they're often the easiest type of seizure to count. So in the studies, they often focus on the drop attacks. And, Epidiolex, when you look at the studies, doesn't really stand out from any other of the medications that we use in Lennox-Gastaut. Studies for refinamide and lamictal and topiramate and clobazam and Fintepla. They all have roughly the same efficacy in that, we at doses of 10 to 20 milligrams per day, we'll see a 30 to 40% reduction of drop seizures. And then you'll get your super responders, the ones that do very well, maybe 5-10%, where it's just magical. We've done great. The benefits are sustained. They looked at an open label extension, and maybe gets even a little better with time, maybe as you can manipulate doses. But the other thing that people have looked at is what about psychotropic benefits on treatment with Epidiolex? And so they've looked at caregiver quality of life scales, and we saw improvements of socialization and communication. And then very similar studies in Dravet syndrome, tuberous sclerosis. Usually you get a good effect at 10%. You may get a slightly better effect at 20 milligrams per kilo per day. But in the tuberous sclerosis study, they went up to 50 milligrams per kilo per day, and that really just caused side effects. It didn't really improve seizure control. What are the side effects we see? Epidiolex is not for everybody, and I think I look at two of my patients here, and I know both families that we tried Epidiolex and we didn't stay on it for very long. Didn't help or cause side effects. They're usually mild to moderate. The main ones are sedation and lethargy, diarrhea sometimes because it's in that sesame oil. Elevated liver enzymes is reported almost always in kids that are also on Depakote, which is one of the commonly prescribed meds. Usually it's just a chemical artifact because they're drugs that are metabolized in the liver, and the recommendation is to monitor liver function tests every 3 months. I don't do that too much. I don't know if Greg agrees with me, but I think he probably does. So
I wouldn't say anything other than Jules.
Okay. Let's have a look.
Depends on how people feel. If they feel fine, you don't have to do it as often.
So when we add Epidiolex, it's usually approved as adjunctive therapy. And the important thing, of course, is that Lennox-Gastaut is approved for seizures associated with Lennox-Gastaut. So it's really not just Lennox-Gastaut, but any type of seizure can occur in Lennox-Gastaut. So there's no reason why it shouldn't work for focal epilepsy or other types of epilepsy. So it's a workaround if we're trying to get insurance to approve the Epidiolex. So I always start low, go slow, starting off at maybe 5 milligrams per kilo per day, maybe even less. We review clinical response, and then if we want to, we can keep increasing in small increments. So CBD is metabolized in the liver, and it's an inhibitor. So there's many interactions. So because, as you know, kids with Lennox-Gastaut, with Dravet syndrome, are not on just one medication, but multiple medications. The most significant interaction is with clobazam or Onfi, where we see an elevation of Onfi levels and of a metabolite of Onfi, which is the N-desmethylclobazam. Stiripentol is a medication which is often used in Dravet syndrome. It's a niche medication for stiripentol, and they're both metabol inhibitors of the cytochrome 2C19, but because if you're already on the stiripentol, and this is just a technical point, when you add the cannabidiol, your levels don't increase. I think there's autism is one of the conditions, and we have a session on autism and epilepsy this afternoon, and autism and epilepsy often go together. It was one of the observations that brought autism out of the psychiatric field, because in the 60s, if you had a child with autism, well, that's because you were a refrigerator mom who didn't know how to give affection, and dad was an engineer and worked with, But when we began to realize that seizures are more common in children with autism, we began to understand the neurological basis. So dysfunction of the endocannabinoid system is a unifying pathology in various subtypes of autism. They regulate the functioning of the brain, the gut, the immune system, as Dr. Barkley's told us. And there are studies which show that improvements in language, restricted interests, aggressive and self-injurious behaviors, irritability, sleep. And I usually recommend that these are children with autism with very severe behavioral trouble with regulating behavior, self-stimulating behaviors, self-injurious behaviors, head banging, punching. And we've tried all the psychotropics we know, and it doesn't necessarily need to be all the psychotropics, but we've tried a few and there's no benefit. So CBD is natural, and but the artisanal products, there's no guarantees with regard to makeup or quality, so you have to be careful. You have to know what you're getting. You have to trust your supplier. The artisanal CBD, and we've talked about the benefit of the multiple phytocannabinoids, but there's no way that this can be validated. Epidiolex has the advantage that it has a standard pharmaceutical preparation. CBD does not necessarily outperform other medications, so it's not a silver bullet for all, but it does add to our armamentarium, and in some cases can be very helpful. It's been most studied for epileptic encephalopathies, Lennox-Gastaut, Dravet, and tuberous sclerosis, but there are reports in childhood of other epileptic CDKL5, Dosa syndrome, Aicardi syndrome, duplication of 15q. Thanks.
While Carla's coming to the stage, I just want to say one thing about what your support for the Epilepsy Foundation of Michigan does. Every few years, there is an authorization bill that takes place on the choice of medications that are covered by Medicaid. And the Epilepsy Foundation teams up with the Cancer Society and other societies and has been able successfully to make medications for seizures a protected class of medications. So for all of you who have Medicaid, every seizure drug that's on the market is a protected medication. It's automatically approved for treatment of your epilepsy. And that is a remarkable achievement, because if you talk to anybody who has a commercial insurance, the pathway to get any of the new drugs for their seizures, which are expensive, is a long, difficult pathway with many barriers of prior authorization. And the Epilepsy Foundation deserves your thanks if you have Medicaid for the ease at which you can get any of these new drugs.
Thank you both so much. I just wanted to quickly mention Proposal 1 that Dr. Barkley talked about that passed in 2018 was largely championed by an incredible woman named Zara Abbas. Zara was a once-in-a-generation epilepsy advocate and achieved many years of seizure freedom from cannabis. She passed away in 2022, but she is always with us. So now we'll have about 15 minutes for your questions. Please keep in mind that our doctors can't provide medical advice for specific individuals, but they can speak generally about this topic. So any questions?
Hello. So I have a question about research of use of cannabis for nursing mothers with epilepsy. So just some background. So I have chosen in my adult life to be completely sober, so I'm hesitant to do any of these things. But while I was nursing my son postpartum, most of my seizures happened during that time. And despite, I talked to my neurologist, and they say so far there's no correlation of nursing and seizures, but that has been my story. And so, though I've been hesitant, to take, I have Klonopin if I need it, but I've been hesitant to take any of those. I have done it, but drugs while also nursing my son. And so I'm curious, has there been any exploration of using low levels of cannabis for nursing mothers instead of some of these other drugs that might have an impact on the child?
Well, that's a great question. First of all, mother's milk has endocannabinoids in it. So your baby is getting endocannabinoids when you nurse your baby. So the question is, if you give levels beyond which are found in breast milk, what effect does that have? We know that all the cannabis products pass into the breast milk very easily, so that there are substantial concentrations of cannabinoid compounds in women who are using any cannabis product when they nurse. The effects of an occasional medication use, once a week or once every 2 weeks is different than the effects of a medication given every day with every nursing for 6-12 months or so. And so I think one has to always say, what is the dose, what is the duration of therapy, and things of that sort. So if you are using any medication as a nursing mother once in a while for your child, it's probably of insignificant effect, just as a general statement compared to using it every day.
I have a question in regards to the workforce. My son had a federally funded job, and when they did the random drug test, he got fired for having THC in his system, even though he has epilepsy and they knew he had epilepsy. And I understand that the federal government doesn't recognize it as legal, but are there any advocacies or groups that are fighting to change that legislation?
So, as I mentioned, the DEA is a police agency, and because it is listed as Schedule I, it has all kinds of implications on sellers of cannabis can't use the federally chartered banks, so you can't use credit cards. Employers can use that as a reason to discriminate against employees. I believe that in the last 2 weeks, the state of Michigan has announced that they are no longer testing for cannabinoids in employees outside of law enforcement and a few other police, like law enforcement, the prison guards, and things of that sort. But there really isn't any protection for this kind of thing that your son had due to the federal laws. And so the way to change that is in 2024 is to look at the positions of the candidates you're voting for your members of Congress. We've got a Senate election coming up, and everybody has a representative in their district. And I would say this would be a worthy question to ask that those candidates for the spots that you have a chance to actually vote for. What are their positions on these issues?
If other questions?
I wanted to ask, for all of us adults and teenagers and children with epilepsy and autism, for the kids and parents that for the kids and teenagers that go to school, taking cannabis, could it help them at school if they needed it, if they were having a health condition and was at the nurse's office, the medicine that they have there for that student didn't work, and they were told that they needed to call for either their father or their mother, the parent of this child, to come and pick them up and take them home. What would you say should be done? Should cannabis be allowed to be in the school and work programs?
Yeah, that's a good question. There's still a lot of maybe ignorance, there's still a lot of fear about artisanal CBD. So I remember one patient of mine that we had on treatment with CBD for seizures, and we could not get the school nurse to administer it. In the end, what we negotiated was a and the girl could carry the CBD on a little necklace on her, so when she needed it, she could take it. So, and even I've had, it's very surprising. I mean, I guess I've had some schools refuse to give Epidiolex. They've said we're not giving Epidiolex because it's, and I say, look, it's FDA approved. So I think it's it can, I think there's always room for negotiation, but there's still barriers.
The Epilepsy Foundation of Michigan has services to reach out to schools, and if you're in a school and you're having issues with any of your medications, that's a reason to contact the foundation, because the foundation has staff that can go out and meet and be your advocate.
We have a question here.
Hi. For those with medication-resistant epilepsy who have maybe tried Epidiolex and didn't have the results that they'd hoped for, would you recommend trying an artisanal type of CBD like the Haley's Hope or the Charlotte's Web?
So there are, I think, when one has treatment-resistant epilepsy, after you've tried several medications, I think that's where it's time to consider whether other kinds of options also might work, neurostimulation or epilepsy surgery. And there are sessions about that at this meeting. Putting that aside, there is there's clearly different responses to different medications by different people, and it may be that part of this entourage, there may be some options. My guess is if you did not find Epidiolex to be helpful, that there may be something about some of these other blends. Again, one has to be careful because THC interferes, you can't go around high and try and go to school and work. So there are some limits to cannabinoid therapy that are just practical, that you have to be clear-headed to be able to do your best in school or at your workplace.
I think we had a question back there.
Yeah, my question is about employment. I've been fortunate. I've worked 39 years. 1920 up in the thumb in plastics, but then I got into Chrysler. Chrysler had no problem hiring me. About the same time, 19, 20 years, more or less, they showed me the door. They knew I had epilepsy in the beginning, but I actually, who Renee replaced at the Epilepsy Foundation, what's your opinion about them telling me, I'm sorry, you got to leave?
Were you shown the door because of you were using cannabis, or just because you had epilepsy? I'm not clear.
As far as I know, it's just because I had epilepsy.
Well, the foundation, so the Americans with Disabilities Act, which was really spearheaded by Tony Coelho, who has epilepsy himself and who was a former leader of the National Foundation, was designed specifically so that people with epilepsy would not be discriminated against in the workplace. And so the National Foundation, as well as the Epilepsy Foundation of Michigan, has staff that try to work with employers to try and help people with epilepsy not get discriminated under those circumstances. So I would say that that's the best approach I would suggest.
Do either of you know anything about using cannabis for rescue medication to stop status?
I've had some people swear by with cannabis for rescue medication. if we did need a rescue medication, there are other commercial rescue medications which are available, nasal sprays particularly these days. And you know, if it was for a prolonged seizure or a clustered seizure, I'd probably recommend a trial of that first, you know.
So actually, this is a very good question, because if you think about how do you, rescue medications can be done by the patient himself or herself if you're in the early stages of a seizure where you're fully aware of what's going on. And under those circumstances, you might be able to self-administer a nasal spray, or if you had, you could vape or smoke some cannabis. We know that in those cases, those drugs are delivered to the brain within seconds and may stop the rest of the seizure from progressing. So there's certainly, and I have patients who use cannabis in that fashion for a rescue medication. A lot of people think they're fully aware when they're started their seizures, but they aren't necessarily as aware of it as they think, and so the rescue medicine is applied by others. And in those circumstances, using in some sort of inhaled cannabis would be risky. And the oral products take time to get into the system. So I would agree with Dr. Constantinou that the nasal spray rescue medications probably would work better in those circumstances.
Okay, other questions?
There's one hand over here. Well, there's lots of hands.
I still don't quite understand it. So I've had 2 brain surgeries, and now I'm thinking about my 3rd one. But I was raised from the streets. When you say marijuana, I just think of weed, smoking weed, and that's something. I'm being honest. It's something I said I would never do drugs. But so what does does it calm the nerve, the electricity or something? What does it do to stop a seizure? So I can get over my viewpoint of marijuana. What does the marijuana actually do with stopping the seizure?
So if you look, what causes seizures is too much brain activity, and you know what drives a seizure is too much excitation, which is too much gas, or not enough break. And I think, it's very complicated and we don't fully understand it yet, but we think that the CBD, which is the stuff which doesn't make you high, right? The high stuff is the THC, so it's not going to make you high, but the CBD works on the dampening system in the brain, on the brakes. So that's the way that with time and sometimes at the beginnings of a seizure, it can help stop the seizure.
Let me use a little terminology. So from historical times, the plant's been known as the cannabis plant. Marijuana is a Mexican slang term that was the cannabis plant in Mexico was referred to in around the 1900s when it began to be imported from Mexico. So most of the time we talk about medical cannabis rather than medical marijuana, but it's the same thing. And of the many cannabinoids in the marijuana or cannabis plant, depending on the strength and the mixture, they all have been shown in various studies to have anti-seizure effects. So it is a drug that is used for people to get high, certainly for party purposes, but it is a medical compound that has clear medical benefits. And I would say, when we've talked about artisanal cannabis, I would strongly encourage people to use products that are available in the dispensaries in the state of Michigan, because they are all tested for pesticides. They're all tested and they state what the ingredients are. And the studies Dr. Constantinou talked about came from other states. And if you've been reading the news, just in the past year, there have been at least 2 different dispensaries that had to pull products because they were not accurately labeled or they had contaminants. So the state actively does surveillance to make sure you're getting what you think you're getting when you buy cannabis through official dispensaries in the state of Michigan. I would not buy cannabis off the street.
And I think we have time for one more question.
Okay, hello. My special needs son has autism and epilepsy, and my husband is also affected by epilepsy. And was just wondering if you could talk a little bit about brain inflammation and seizures and how CBD can help, how it supports an individual. And also, where would locally a good supply, where would you go for CBD that you would have a safe strain to use and that you know what you're getting? Thanks.
Yes, I think inflammation is a very important topic. And I think we're beginning to recognize that inflammation in the brain is important in many disease processes, and I think we're just beginning to understand that there's an inflammatory component to epilepsy. Maybe there's an inflammatory component to tics. Maybe there's an inflammatory component to autism. I think classic neurology, though, is maybe still catching up in terms of the game, and we still a lot that we don't understand about it, and I think so we are learning more and more. We do know that CBD, cannabidiol, does have anti-inflammatory properties. We talked about how CBD2 is expressed in the microglia, which are sort of like the scavenger cells within the brain, clearing up bad stuff and toxins and helping synapses form. So I think that's a very good question, and something that, I think there's so many cannabinoids to explore, and CBD is just one of them. There's the CBGA that we were talking about, CBVD, which is people talk about in autism. In terms of who you go to and where you go to, that's just such a tough question. It's we do have some dispensaries that we can recommend, but they come and they go, and we've had, I have a good source for a couple of years and then they fall by the wayside. So it is very tough.
There is a specific autoimmune epilepsy and inflammatory epilepsy that is well recognized by epilepsy experts, and it is treated with steroids. There was a popular book written about 10 or 15 years ago called Brain on Fire that talks about a reporter's experience with that. So we recognize that there is an inflammatory aspect to epilepsy in some patients, at least.
All right, thanks everyone for some great questions. And now I'd like to invite Renee back up, our Community Care Director, for some announcements. And thank you, Dr. Constantinou and Dr. Barkley.